Okay, hello everyone, and welcome to From the Experts, brought to you by the Sumaira Foundation with support from Horizon Therapeutics. My name is Sumaira. I am the founder and executive director of the Sumaira Foundation, also known as TSF. I am a patient living with neuromyelitis optica. I got diagnosed about 8 years ago and started the foundation 1 month after getting diagnosed. And since then have essentially dedicated my life or whatever free time that I have to raising awareness for NMO, MOG, fundraising to support research, bringing the community together in meaningful ways, and patient advocacy. So I'm really excited to introduce you guys to Dr. Barry Singer out of Missouri. But before we introduce him, just a couple of housekeeping items. As you know, this session is recorded and it will be available for replay on Facebook and on YouTube. So definitely hit the like and subscribe button so that you can keep up to date with all of our content. There will be an opportunity to ask Dr. Singer questions at the second half of the program. So don't be shy and please populate your questions in the Q&A function of this webinar. And without further ado, I am very pleased to introduce all of you to Dr. Barry Singer, who will be talking about spasticity and weakness. Thank you.
All right, thank you, Sumaira. So it's a pleasure to be here, everyone, and I am happy to start presenting about the treatment for NMO and MOGAD in terms of weakness and spasticity. And so I'm a director of an MS center in St. Louis. It's called the MS Center for Innovations in Care, and have been treating people with NMO, MOG, and MS for a long time. So I've been at my kind of in St. Louis in the same clinical practice for 22 years. So a lot of experience, and I'm happy to kind of share those insights with you all. So so let's start off with weakness. So what do we mean by weakness with these conditions? So with MOG or NMO. So weakness can affect different parts of our body. Sometimes you can actually get a facial droop, which is weakness, but in general, we think about weakness in the arms and legs. And so if you have frequently with these conditions, you get an attack to the spinal cord, and that can lead to significant weakness. Now, your cervical spinal cord controls your arms. So if you have an attack in the cervical spinal cord, it would get your arms and potentially your legs. And then the spinal cord comes down, and then there's a thoracic spinal cord. So the cervical spinal cord does like your neck. There's 7 vertebrae in your neck, so that's your cervical spinal cord. And your back, your mid-back, is your thoracic spinal cord. And if you have an attack in your thoracic spinal cord, it can cause problems in your legs, but not your arms. So it really depends on where the attack is and how you might be affected. Specifically, these conditions in terms of MOGAD or MOG-associated disease, the MOGAD can attack the coating of the nerves of myelin and cause injury into the spinal cord. And when we think about NMO, there's an immune attack on the water channels on cells called astrocytes, leading to injury. Both of these types of injury can directly affect not only the white matter, but they can very much tend to affect the gray matter of the spinal cord, which is the central part of the gray matter, the central part of the spinal cord. So there can be this immune attack, and both conditions are associated sometimes with a very long lesion within the spinal cord. So with MS, we tend to see like a lesion or attack in the spinal cord that may affect 1 or 2 vertebrae at a time. So a small segment of the spinal cord. But with MOGAD or NMO, it tends to be a much longer area of the spinal cord that can be affected multiple levels, sometimes extensive areas in both the cervical and thoracic spinal cord. So that's why weakness can come on pretty abruptly. And so unfortunately, I've seen with NMO, for example, I've seen people go from a little bit of weakness in their legs to not able to move their arms and legs within 24 hours, which can be pretty terrifying. And you can also see attacks that, where it could be one side of your body. It tends to be a little more symmetric with patients with NMO and MOG. Now, you can get your brain affected with both the conditions, more commonly with MOGAD than with NMO. And so lesions in the brain, like one side of the brain, could cause weakness on the opposite side of the body. But when you see symmetric symptoms affecting both sides of the body, then it tends to be a spinal cord process. And so, this weakness can be acute. And so if it happens suddenly or acute, we would consider that a relapse. And so what will we do if you suddenly, can't move your legs or your legs are extremely weak? How do you treat that acute relapse? With both conditions, NMO and MOGAD, we tend to use steroids. So methylprednisolone, it tends to be our go-to, and some of you may have had that before. And so we infuse people with IV steroids. So generally 5 days for a bad attack. And so these are infused into the vein. Now, the risk of that include increase in blood sugar. So we're going to have you watch your carbs during that period of time. If you have diabetes or some people that are a little overweight, their blood sugar can go up, and that could be a problem. So we would need to monitor that. And then we also look at if you don't if you have that after you get your steroids and you're not better, then frequently we start looking at other options. One of those is called plasmapheresis. And plasmapheresis is kind of like dialysis. And what we do is that catheter or port is placed and into the vein, sometimes in the neck. And then we suck out the antibodies in the circulation. So the MOG antibodies or the NMO antibodies, you take out antibodies in the circulation. And you can see some dramatic improvement sometimes with plasmapheresis. There's different ways of doing it. Typically, I do one procedure, one pheresis every other day for 10 days. So it's kind of a long, drawn out procedure, but it really can help someone get over that acute attack. And so that's really important. And I've even sometimes, even though we're doing 5 days of steroids, sometimes on day 3, I'm already starting with plasmapheresis if it's a severe attack in order to see if we can get some recovery. It's very important, particularly in patients with NMO. A lot of times people end up with significant disability after an attack. So aggressively treating that attack up front is very important. Tend to have a little better recovery with MOGAD. With patients with MOGAD tend to recover better from an attack than those patients with NMO. And then other strategies for patients with MOGAD, for example, is IVIG, which is infusing antibodies through the vein during treatments, and then also prednisone. So some patients with MOGAD are kept on steroids for approximately 6 months, and that's been shown to be effective for some people. So we want to treat that acute relapse up front in order to control the disease. And in addition, we think about more chronic weakness. And so what do you do if you're dealing with weakness for a long period of time? So how are you going to go about controlling that and managing with it? So some of our patients have, let's say you have weakness in your legs. Well, mobility is going to be the biggest challenge. So one of the great ways to deal with mobility or trouble walking would be physical therapy. And so having physical therapists, especially with some experience, because NMO and MOG are fairly rare, it's going to be hard to find probably a therapist that has a lot of experience, except for maybe in certain centers. But it is important to find someone that maybe has some experience with multiple sclerosis patients, because that probably would help. And so that can work on a few different things. So the physical therapist can help with gait evaluation. So one of the things we want to do is look at how you're walking, how you're stepping. Are you, is one of your legs swinging out when you walk? Are you wobbly, or your risk of falling? So they'll look at your whole gait and try to assess it and see, maybe you need assistance, maybe you need a cane or a walker to ambulate and to walk. So I think that's really important to have a good physical therapist on your team to kind of help you navigate that. In addition, that therapy is going to be important for determining an exercise regimen. So exercise is really, really critical. So if you have a leg weakness, you may want to start thinking about options. One of them I like is a recumbent bike or an exercise bike. And so you can get on that bike and then just, you don't have to worry about your balance and you can build up your leg strength. I had some patient in today who said, oh, I'm getting slowly weaker, a little weaker. And, part of it is not a lack of exercise. So really that exercise is really important, critical to keep your strength up. And then you want to also look at swimming is good for a lot of people so that you don't have to worry about your balance, water aerobics, water exercise. Yoga is very good because it helps with stretching. So all that's really important to work on building your strength. So how do we treat weakness? Improving strength, I think, is really important. And then with weakness in the upper extremities, occupational therapy can really help. And they can help you learn how to do, the occupational therapist can help you do your day-to-day activities. How do you open jars if your grip is reduced? What about typing if typing's a problem, or using eating utensils? So they can really help you navigate and kind of adapt to disability if you have disability. Another really important part of weakness is, weakness or legs. One the reason why we have legs is to get from point A to point B. And so if your legs are weak and your mobility is disrupted, then unfortunately, I think a lot of people they feel like the world is getting more narrowed. So they're not able to go out and do things because if you walk more than 10 yards or 50 yards, you really get worn out and have to sit down. And you're not able to go do some things, activities that you want to do. So we don't like that to happen. So what we really want to do is focus on those activities that we want to work on ways that you can improve your mobility. So for some people that requires devices. So some people with NMO or MOGAD have foot drop where their foot's dropping down. Well, there's something called an ankle foot orthosis, which is basically a device. You basically have a strip of a metal, so to speak, that comes down, and then a foot plate that goes underneath your foot. And so this device, which is velcroed around your calf, allows your foot, instead of dropping down, keeps your foot up. And so it prevents that foot drop. So you don't have to lift your leg so high to get that to walk. And so that can help. There's also some electronic devices called Bioness or Walk Aid that can help with foot drop. And then we also look at devices such as a cane. Some people need a cane in order to help steady their balance, help not getting knocked over. And some people just need it when they walk distance, or so that can make a big difference. And then mobility devices such as scooters or walkers or even wheelchairs or electric wheelchairs really can make a big difference in terms of allowing someone to be independent. For example, if you want to travel, some people actually have an electric wheelchair delivered to their hotel so they can go to Disney World and they can go to various places. So as the world opens up, we still got to be careful if you're immunosuppressed, but as the world opens up, we want to look at those different mobility devices. The other things that we start thinking about besides weakness is spasticity. And so what is spasticity? And so spasticity is a condition in which your muscles get tight or stiffen. And it really prevents that normal fluid movement of the muscles because the muscles remain contracted and resist being stretched. So your muscles get tight and stiff. And that is called spasticity. And spasticity is a big issue for people with weakness with either both NMO and MOGAD. And that stiffness can be a real problem, spasticity. And what we see, like if you come in the examination room and we try to test you out, and we'll find that you do have some resistance while we're trying to stretch your legs, or if I try to lift your leg off the bed, it just kind of comes straight up, straight like a board. And so that can lead to problems. Some people are very strong, but due to spinal cord injury, they are very stiff in their legs and they kind of walk bow-legged, and it reduces that fluidity or that smoothness of the gait. And so we have to kind of work on ways to try to reduce that spasticity. And there's a lot of different options there in terms of what we do. One of the most important ways is stretching. So stretching can make a huge difference. Just there's exercises that you can learn. The yoga is another way of helping with the stretching. But stretching exercises, a physical therapist can show you how to do that. It makes a really big difference. And it's a way of doing that without taking any medication. And then for some people, the spasticity is definitely worse enough that we want to start thinking about medications to loosen the legs. And this includes one of the most common medications used for spasticity is baclofen. And so baclofen's been around for a long time. And we start with somewhere about 10 milligrams, but you can go up to about 30 milligrams 3 times a day, and really can help with loosening those legs up and help with cramping and tightness at night. Frequently, it does happen at night, but it can happen during the day. Most people tolerate baclofen pretty well, but some people makes them drowsy and they can only take it at night. So you just kind of trial and error to see if it works for you. If your legs are too weak, and you add baclofen, it can make your legs a little too loose. And then I call it noodle legs. So the stiffness, some people with weak legs helps because they're almost like poles helping you walk, or crutches that are helping you walk. And if you loosen it up too much, then that can be an issue. So we got to kind of find the right balance in terms of the dose. Another medication that's commonly used for spasticity is tizanidine. And tizanidine is another muscle relaxant that works differently than the baclofen and can be combined together. Again, tizanidine, it can really loosen up the muscles. And, some people tolerate it well, some people make them drowsy. So it's kind of hit and miss. And even if you get drowsy on baclofen, you might tolerate tizanidine well, and vice versa. So tizanidine, some people just take it at night, so it helps with spasms at night, but it can be taken around the clock. And we usually start with 2 or 4 milligrams, and you can take up to 12 milligrams 3 times a day. For some people where those medications don't work, we look at diazepam. And so diazepam is another muscle relaxant, and it's also known as Valium. So it is a very potent muscle relaxant, but the downside is it can be somewhat addictive. So some people take it around the clock, but other people take it just when their spasms are pretty severe. So that can definitely help. There's very little data on cannabis. So in the world of MS, we know that the combination of THC and CBD has been shown to be helpful for spasticity. And in Europe, there's a cannabinoid product available that's an aerosolized spray. But very little data. I actually just did a literature search last night. Very little data on the use of cannabis for people with NMO or MOGAD. But again, it is important to address spasticity with your doctor. Painful tonic spasms. So what are these? So one of the really horrible things that I've seen with people with NMO and MOGAD are severe spasms. And so the spasms include, all of a sudden what happens is maybe your arms will straighten out and be pulled straight out, or flexed. So the arms come back up and get flexed. And so these are flexor spasms and extensor spasms. And this can happen with the arms and legs. And they may last a few minutes, sometimes seconds, and they are very severe and sometimes very painful. And it's very horrible to watch people dealing with this. And it can be very uncomfortable, and they can reoccur. So they can occur numerous times per day. So it is important to keep that in mind. And so what we want to do is, when we think about people with NMOSD, neuromyelitis optica spectrum disorder, about 75% of patients living with this condition have pain associated with it. About 66% of patients have neuropathic pain. But 69% specifically have spasticity associated pain. So the spasticity can lead to significant pain. And these painful tonic spasms can occur in about 26% of people with NMOSD. So the people with NMO, about a quarter of them will have these painful tonic spasms. Some of you out there may be dealing with this and know just how uncomfortable it is. If you think about, it's a little different with MOGAD or MOG-associated disease. So about 50% of patients with MOGAD have pain, and about 35% of patients with MOGAD have spasticity-related pain. So how do we treat these painful tonic spasms? So the most usual way that we deal with this is certain seizure medicines. One of those is oxcarbazepine, also known as Trileptal, and another one, an old seizure medicine as well, called carbamazepine or Tegretol. Tend to use more oxcarbazepine. It's less likely to cause some problems with your liver enzymes, liver blood tests, or platelets. So I find the oxcarbazepine is a little cleaner. The downside, about 2.5% of people can drop their sodium on this medication. So we check blood levels of sodium, and sometimes that could be quite serious. So it is important, if you go on that drug, that your sodium level be monitored. If you are on a diuretic water pill, then that risk is even higher on oxcarbazepine. But these drugs can be miraculously in terms of stopping NMO attacks, and I've had some great success by starting these medications. They were also compared to other medications. One, for example, it's called gabapentin, which is a drug that works really well for nerve pain. It does sometimes help for these painful tonic spasms, but not as effective. And then there's other options and things that have been used, including another medication called clonazepam, which is in a class called benzodiazepines. And then we've also seen barbiturates, and some of the baclofen cannabinoids have also been used. And even some other seizure medicines, such as topiramate or levetiracetam. So these are other seizure medicines that can help those painful spasms from stopping. So it is important that a lot of this is trial and error, but work closely with your neurologist or healthcare team. If you're dealing with stiffness and spasticity, really there's a lot of different options out there. Some are non-pharmacologic, again, stretching, yoga, and those type of activities can really help. And then if it's starting to get painful, then we can start thinking about what those options are. But we don't want you living with this and suffering, and we really have these options. For some people, if it's really bad and painful, then we can start to look at other options. For example, Botox can be given into the muscles to relax them. And then another option is a baclofen pump, where you actually put a catheter, goes into the spinal fluid and drips baclofen directly into the spinal fluid. And there's a pump that's inserted underneath the skin. And so that gives the baclofen right into the spinal fluid. So these are options if we need some additional help. So these are other ways to help deal with the spasticity. So in general, the goal with pain and with a painful spasticity or with weakness in general is trying to improve your quality of life. If you're having an acute attack, let's get on top of that very quickly. IV steroids, plasmapheresis, and then fortunately, we have highly effective treatments now that we never had before. Over the past few years, we have some very highly effective FDA-approved treatments for NMO. Growing research on MOGAD, it's really just taken off, and so we have some effective treatments. But it's really good symptomatic management to help us deal with that weakness and spasticity. So at this point, I'm happy to open it up for questions from you all. Let's see what we got going on here. All right, so one question that's coming in, we got a few questions coming in, one in the chat. And so I have seronegative NMO, and plasmapheresis has relieved my symptoms. Why does it work if I don't have the antibodies? So this is an excellent question. So what do we mean by seronegative NMO? So seronegative NMO means someone with neuromyelitis optica, presumed based on criteria. So we look at different things like, for example, if you have optic neuritis, if you have a long lesion in the spinal cord, If you have, there's an area of the brain, the brainstem called the area postrema, which can cause hiccups and different symptoms if it's attacked there. So if you meet some certain criteria, we can diagnose it even though you don't have NMO antibody positive. Interestingly, about half of the patients that are seronegative that seem like they fit with NMO can actually be MOG positive. So it's obviously important to check that out. So definitely we see that plasmapheresis can work. We also see it works in multiple sclerosis. So I think it would work even though you don't have antibodies. Maybe we're not measuring the correct antibody and then you don't have the NMO, the NMO antibody, which is called the aquaporin 4 antibody. Aquaporin 4 is the water channel on cells called astrocytes. And so with NMO, we see that antibody that attacks that aquaporin channel. So aqua being water, porin being whole. So it's a water channel. And so the antibodies attack that in the nervous system. And so if you're seronegative, you don't have those antibodies, but there may be some other antibody that we're not measuring. So that's why you may respond to that treatment. All right, well, thank you for that question. Here's another question. Can oxcarbazepine, baclofen, gabapentin, or clonazepam actually cause the tonic spasms? And the answer is that is no. I've never seen anybody on these medications causing it. The disease causes it. And unfortunately, NMO and MOGAD can actually attack the spinal cord. And so they're attacking the gray matter within the spinal cord, which can trigger it. It's almost like a firing of the nerves where you get the boom, the spasm hits. And these medications, particularly oxcarbazepine, is a anti-seizure medication. So it helps, it affects sodium channels and prevents, and the idea is to prevent those nerves from firing. Again, baclofen is a muscle relaxant, and clonazepam is kind of affects a chemical called GABA, and the idea is to try to reduce these activities. Then another question: how often should the sodium levels be checked if you're on oxcarbazepine? And so I tend to check it a couple of weeks after someone starts, and I tend to check it if I start cranking up the dose and start increasing the dose. I've definitely had some patients on this drug who ended up in hospitals because they never got any blood tests on it. So it doesn't happen that often. It tends to find that happens when someone's on as I mentioned, a diuretic. So like something called Lasix, for example, or furosemide. So if you're on a drug that is a diuretic, that might put you at a higher risk, but it is important to just check just to be on the safe side. Now, if your sodium level runs a little low, it's usually not a big deal, but if your sodium is getting under 130, then it's a concern. Normal sodium runs are between 135 and 145. Okay, so here's someone else who said, I have a lot of spasms and I'm taking Vimpat or lacosamide, but still having a lot of burning in one of my legs. Does it get better by the time? Yes, I mean, definitely symptoms improve over time, particularly if you had an acute attack of NMO or mog-ad, then, you know, things can improve and you can heal over the course of a year and improve. Tend to have better luck with MOGAD than NMO in terms of recovery from attack. Many people with NMO don't make complete recovery, and that's why these treatments are so important to try to prevent future attacks. But if a medication is not working great, despite you still having spasms, it's a good idea to really sit down and look at all the different options out there. Is it possible to differentiate between nerve pain and spasms is another question. Yeah, so spasms tend to be like really tight cramping tightness, and you tend to get this painful tonic spasms, this tight rigidness to the arms, the legs. And then the nerve pain would be more issues with like burning, pins and needles, tingling. So that would be more nerve pain. And I tend to use with nerve pain, I would be looking at more drugs like Neurontin or gabapentin. pregabalin or Lyrica, and Cymbalta, I think are some great options, or the other name for Cymbalta is duloxetine, which is also an antidepressant, so sometimes kills two birds with one stone. So those drugs I tend to use for more nerve pain. Gabapentin is sometimes used for spasticity, so it can sometimes bridge that, but I tend to use more Cymbalta or Lyrica for specifically for nerve pain. Amitriptyline is another option, sometimes causes some weight gain, but amitriptyline is another option for nerve pain. So here's a question. Is it common for spasticity to spread? And so that's an important question. Can it spread, from the calves, now in the ankle and the feet? It definitely can. Usually not, MS is more likely to develop a progressive course. So people that have had MS for a number of years can go into secondary progressive disease where the disease is slowly getting worse. One of the difference between MS and like NMO and MOGAD is NMO and MOGAD are really driven by relapses. So incomplete recovery from a relapse can lead to some disability. So it's unlikely to just gradually progressively get worse for spasticity to worsen without new lesions or new attacks. So if you have one bout and then you have another bout, that spasticity could spread to new areas like your arms. And so that would be a concern if you are having new attacks to the nervous system. So we want to try to avoid that. Some people though do have, like more as the person asked, some people have it in the calves, and then sometimes it can spread to the feet. But if you start seeing a new area of the body, then you've got to be worried about there's new disease happening. And maybe, and that would be a good time to do another MRI, see if anything else is going on. Does the sodium level need to be checked regularly on carbamazepine? Yeah, so I think it's a good idea to check labs on that. I tend to check blood count as well. Occasionally there's low platelets on carbamazepine. And if you're starting to get to pretty high levels with that drug, there's also drug levels that can be checked. One of the downsides if carbamazepine gets too high, for example, you might get some drowsiness or double vision. So it is important that if you're on a higher doses of that drug, that you check those levels. So I think it's a good idea for that to be periodically checked as well. So another great question there. All right, well, keep them coming. I'm here to help out. So let's see if there's any more questions. A lot of great questions. And there was another comment, someone was commenting about that they are on treatment for their NMO. And I think that's really important. We have some very, very effective drugs that reduce the risk of having new attacks. And that's been really monumental. I've been treating people with NMO for a long, long time. And and I've seen some people really have devastating effects, including blindness and quadriplegia, and even unfortunately some people who have died far too young for their, based on this disease. And really, the new treatments are really pretty incredible in stopping the disease. So it is important that if you have the condition, explore what your options are, no matter where you live globally. I think it's really important to get on highly effective treatment, and well worth it. So even if you're feeling good on treatment, just keep it going, because that's going to be extremely important. All right. Here's a very important question. Does spasticity cause swelling? My feet have changed so much. So that's an excellent question. So spasticity itself does not cause swelling. And, interestingly, with spasticity, even though people have weak legs, we don't see a lot of blood clots in the legs that you expect for people that, despite having weakness in the legs. And that's because that stiffness helps pump the blood back. That said, some people with very weak legs can develop swelling in the legs. And so swelling in the legs, if you have swelling in the legs, it's sometimes very weak legs can cause some what we call edema. And it's not uncommon for weak legs to sometimes be purplish or mottled and change colors, but generally, so that's not uncommon to have it. But usually the spasticity itself doesn't do that. It's usually just weak legs, sometimes are swollen. So that's common. And the discoloration, kind of the mottled purple, blue, red sometimes, is not dangerous. It's just one of the side effects of having weak legs. One of the questions came up about, it was actually asking about a multiple sclerosis drug is a good treatment for MOG. Right now, we don't have any approved treatments. So all the MS treatments, none of them have been approved for MOG. We actually have nothing that's FDA approved for the treatment of MOG. But one approach is B-cell depletion. So some people, there's in the literature, some people have used rituximab, which is a drug that depletes B cells. And so it's something that I've actually used for some of my patients with MOG. So B-cell depletion would be an option, but there are other options for the treatment of MOG. But someone asked me specifically about a brand name drug for MOG, but we don't have any of the currently approved B-cell depleting drugs that have been approved for MOG. Someone else brought up the fact that they had swelling in their hands and feet on Lyrica, which is also known as pregabalin. And that's true. So we definitely see one of the side effects of Neurontin, gabapentin, and Lyrica is swelling. And occasionally drowsiness and gait imbalance. They're in the same class and they work similarly. So swelling is a potential side effect of those drugs. So, if it's a significant amount of swelling, then you may need to discontinue and look at other options. But again, those drugs tend to be used for neuropathic pain, which is burning, pins and needles. Interestingly, the pain pathways with NMO and MOG are often hit because they run through the central area of the spinal cord. So there's this pathway that controls pain in the spinal cord called the spinothalamic tracts. And these pathways down the spinal cord are in the central part of the spinal cord. And so they're often affected by the immune attack in the spinal cord. So we tend to see with NMO and MOG sometimes a lot of pain, and we think it's because of the damage to those pathways. So here's a question. If a person's having banding, what medicines can help with banding? So banding, I assume this person, you could kind of clarify, but the banding, a lot of people get like a band around their torso, kind of like a strip around their torso of squeezing. In the world of MS, we call it the MS hug, and it feels like it's tightness around the spinal cord, around the chest wall. And it goes all the way around. It's a tight squeezing, kind of boa constrictor tightness, and very uncomfortable. Some people have burning or pins and needles with it. And I tend to find that this kind of hug sensation, which we call the MS hug, but you can see it in all these conditions, I tend to find two approaches work for that. One is sometimes things for nerve pain. So we use sometimes the Neurontin, Lyrica, go that route. And then other people, we tend to use the muscle relaxants and seem to work better, such as the baclofen and tizanidine. So I kind of play around and figure out which one kind of responds, but I see some people respond to one treatment, one more the nerve pain medicines, and other people seem to respond better to the muscle relaxants. So it's a bit of trial and error, but generally we can get that under control for most people. And because the thoracic spine is very frequently affected with these two conditions, MOG and NMO, it is important that we explore those treatment options. Here's a question: is how do seizure medications work on the tonic spasms? Well, when we think about tonic spasms, it's kind of like this boom, the sudden firing of the nerves that lead to the neurologic symptoms. So how the seizure meds work, they work on channels, which include sodium channels, and they kind of stabilize things. So the nerve is less likely to fire. And because these channels are involved in electrical activity and the conduction of the nerves, what we can do is stabilize that so the nerves are less likely to fire. So you have that severe pain. Sometimes there's another neurologic condition, for example, trigeminal neuralgia, which can affect your face, and it's electric shooting pain in the face. And again, seizure medicines help dampen that down. So we use some of these same medications to prevent that. So what we want to do is prevent that firing of nerves. Another question came up. My tonic spasms also cause itching in the scalp in addition to the flexor spasms. So that's interesting. I definitely get, I haven't seen itching in the scalp associated with spasms, but that's kind of interesting. Sometimes itching can be a nerve type thing. So there are people that have itching as a sensation of nerve pain. Haven't seen that quite a lot, but interesting observation. So thanks for sharing that with us. Can Carbamazepine cause swelling? No, I have not seen that. I don't think that would be a common symptom. And can pins and needles and burning go away if it's due to longitudinal extensive transverse myelitis? So if you have a very long lesion, can the pins and needles go away? Yeah, frequently they can be. So some people have improvement over a year. Now, if you're out, 2-3 years and you still have burning pins and needles, it's probably there for quite some time. But the good news is there are a lot of medications that can help improve symptoms. So if you're really struggling with pins and needles and burning, it's really important to talk to your neurologist about the array of different options. Again, I mentioned the most common ones I use tend to be Neurontin or gabapentin, Lyrica or pregabalin, duloxetine, which is Cymbalta, and then I start working on some other ones. Carbamazepine, sometimes I use for nerve pain. Topiramate or Topamax I use for nerve pain. Levetiracetam or Keppra I use for nerve pain. Amitriptyline definitely can help. You just kind of have to watch out for weight gain. Make sure you eat chocolate sometimes. So we have a number of options on that front in terms of for helping someone with nerve pain. Great questions, guys. All right, let's see if we got any more here.
This is the most engaged group I have seen so far. You're good at this, Dr. Singer.
All right, well, that's good. I'm glad people, well, you asked me what topic I wanted to pick, and this is a huge issue for people living with, NMO and MOGAD. I mean, vision and weakness and spasticity are the big issues. And so we really want people to explore their options. And I think that's really, really critical.
I have a question while people are thinking about their next question. We have 10 minutes left. So I got on Cymbalta about 3.5 years ago, and it helped me tremendously with the spasms and the nerve pain and the paresthesias and all that. But, I'm a young woman and I hate the weight gain that came with the therapy. And no matter what I have tried, whether it's diet or exercise, intermittent fasting or whatever, it seems to be so hard to shed weight with Cymbalta. Now, is that the case for all of these therapies? Is there a trick that you know of that will help us? Because I know that this is a very common complaint in our community.
Interestingly, I mean, I've been using a lot of Cymbalta, I don't know, 20 years or so. I don't see a lot of weight gain in my practice with it. Now, I will say, like, some of these drugs, definitely nerve pain, like I definitely see amitriptyline. I mentioned that, make sure you eat chocolate. People are scrounging around in their cabinets in the middle of the night. Lyrica, I definitely see maybe a third of my patients gain weight. Some people think they see with gabapentin. I really don't see that much. But I really haven't seen in my practice a lot of weight gain from Cymbalta. It is a pretty good drug. I think the advantage of it is not only for nerve pain, it's a great drug for anxiety and depression. So I kind of like it. It kills two birds with one stone sometimes, particularly people who are newly diagnosed. It's a lot to, just get diagnosed with NMO or MOG. It's kind of hard. And I think it really can make a big difference. But I haven't seen a lot of weight gain. I mean, you could always sometimes a low dose works. So you could cut back on it. I mean, they come in 30 milligrams and even 20 milligrams. I mean, most of my patients are in 60 or 60 twice a day, but sometimes you could cut it back down if it's not that. It is important to keep in mind, like people with NMO can have other autoimmune diseases. So thyroid is a big one. So, you know, we want people to have their thyroid checked and start to look for other things. You know, we see a lot of I see a lot of patients with PCOS, polycystic ovarian syndrome, and other conditions that lead to unexplained weight gain. But I don't see a lot on Cymbalta, but unfortunately, there's not a great quick switch unless you're going to do a combination of like, you know, some of these other meds, gabapentin, Lyrica, you know, kind of play around. Yeah, so we just kind of play around, see what works best for people.
Looks like we have a couple more questions.
All right, good. All right. All right. My symptoms have been increasing, such as spasms, creepy crawlies, weakness, and numbness, but recent MRIs do not show any worsening or new lesions. Could my body have adjusted to the medications? Could I just need an increase in dose? So for, you know, it's always concerning, you know, if you're having increasing symptoms. So I would definitely circle back with your doctor. You know, if you have a lot of you know, old disease on your spinal cord, may be hard to see some new disease, so that may be a concern. And then, but you know, you should rely on your own instincts. So if you're, you know, you feel like your symptoms are definitely worsening, then I think you should approach it with your provider, and it may be an adjustment. So sometimes you do have to bump up the medications. A lot of people are pretty stable. You know, when I put people on doses, they can be stable, but you know, there's a range of, you know, particularly drugs like gabapentin, there's a big range that you can go up on. You know, that some people are on 300 twice a day. I've seen people on 1800 milligrams 3 times a day. So, you know, some people can take a high dose and some people can only handle about 200 milligrams 3 times a day. So some people can only handle a little dose. So, but that could be adjusted to try to get you feeling better. But it is important if you feel like the disease is worsening in front of you, then really circle back with your provider. Fortunately, we have more than one option for the treatment of NMO, and the 3 approved treatments all work differently. So you can circle back and see if you're on the right track. Excellent question. All right, here, do your patients have an MRI once a year to continue seeing how things are going? I think that's definitely could be an option, particularly early on. I think it would be a great option is to kind of monitor how you're doing. Fortunately, our drugs have gotten these new treatments are so effective. You may not need a scan every year once you're, you know, kind of in the swing of things and you're on it for a while. But particularly early on, and make sure that you got good disease control, I think is very reasonable. The one nice thing, I mean, one thing that's with NMO and MOG is it tends not to, particularly with NMO, you tend not to get lesions in the brain. Some people do, and there are some people that do, but most it's optic neuritis and spinal cord disease. So you tend to get symptoms if there's something going on. But as opposed to MS, where we frequently see new lesions, even though people aren't having symptoms because it tends to hit the brain. Now, MOGAD, you definitely could have new lesions with without having direct symptoms. But MRI is a good way to keep an eye on that. Now, another question, which is a great question, can you take gabapentin and Cymbalta together? And the answer is yes, yes, yes. So I have many patients. Gabapentin, I do not mix with, which is Neurontin, I don't mix with Lyrica or pregabalin because they're in the same class. So Lyrica and pregabalin and gabapentin and Neurontin, I do not mix. But Cymbalta can be, because it's an antidepressant in a different category, you can mix those together. And some people, that's the best way to control their pain. Do you take patients off gabapentin if they've been on it for a period of time? Well, you definitely can stop at any time. There's no withdrawal from gabapentin. Gabapentin kicks in about 20 minutes and it's out of your system in about 6 to 8 hours. So you can always hold it and to see if it's doing anything. I don't want people on meds that they don't need. So it's one of those medications that could be given if you need it, and then held if you know, you don't think you need it. So I think that's a great question. But always, you know, always make your treatment decisions in context with your healthcare provider team. So, reach out to them before you stop or start any medications. I think that's really important. But gabapentin, you want to make sure that it's providing some benefit. Cymbalta, you don't want to just abruptly stop because it is an antidepressant. You want to make sure you have a game plan on that front. But gabapentin could be just held at any time, and you would find out. I kind of say it sells itself. So if it's helping you, keep taking it. Great questions.
Great. So that actually, it's time to wrap up, but it was a great session. It went by super fast for us. I hope it was fun for you, Dr. Singer.
Yeah, thank you, Sumaira, for having me on. It's a pleasure to kind of help out the NMO and MOGAD community.
Absolutely. So for everyone who is on here, thanks for joining us tonight. Please get some dinner if it's dinner time where you are. This episode or webinar will be uploaded onto our Facebook and YouTube libraries shortly. If not tonight, it will happen tomorrow. Dr. Singer, thank you so much for being here, and I hope we get to collaborate with you soon.
All right. Thank you, Sumaira, and everyone, best wishes to you. Stay well out there.
Happy NMO Awareness Month, everyone. Thank you.